Today we will study about esophagus. Look at this guy. This is Ice Cream Man. His name is Pramod. All the children's asking to their parents or sisters, Didi, see, dekho, Pramod vanilla. There is vanilla ice cream in his hand. So all these are subheadings on which we have to discuss, that is definition, dimension, curvature, constriction, parts, microanatomy, development, vessels, artery plus vein, nerve supply, lymphatic, as well as the clinical significance. First come to definition. What is oesophagus? It's a long muscular tube, extends from the pharynx up to the stomach. This whole thing in purple color, this one is pharynx, composed of three parts. Above, just behind the nasal cavity, this one is nasopharynx. Behind oral cavity, here is oropharynx, and just behind the larynx, this is laryngopharynx. Now coming to dimension and curvature. It is 25 centimeter long tube. Esophagus is 25 centimeter long tube having lumen. Its dimension is 2 centimeter and its length is 25 centimeter. It shows curvature anteroposteriorly as well as side by side. Anteroposteriorly, first it shows convexity along the convexity of cervical vertebra, and then concavity, which is along the concavity of the thoracic vertebra. And regarding its lateral curvature, it tilts towards left side at two places, that at the level of thoracic inlet and at the level of T7. Now coming to constriction. This is what we are seeing is the incisor teeth, and this is a long tube. It is constricted at four places. First, at the cricopharyngeal junction. In the pharynx, there are three circular muscles: superior constrictor, middle constrictor, and inferior constrictor. Inferior constrictor is made up of having two parts, that is thyropharyngeus and cricopharyngeus. And the cricopharyngeus is the lowest one at the junction of cricopharynx, and this is oesophagus. Here is the cricopharyngeal constriction, which lies at the level of C6. Second constriction is by the arch of aorta, third by the left bronchus, and fourth where it enters into the diaphragm through the oesophageal hiatus. And these demarcation are somewhat fixed, but how will you memorize? Just look at constriction of oesophagus is same as that of constriction of our freedom of life. Our freedom of life is constricted. Yes, this is true. First constriction at cricopharyngeal junction, 13 centimeter from the incisor teeth. Here it is written 15 centimeter, but actually it is 13 to 15. So 13 centimeter from the incisor teeth. At the age of 13 only, we have to listen that you are no more a child. Come on, grow up. So this is the first constriction in our life, the freedom of life. C for child and C for cricopharynx, which is 13 centimeter from the incisor teeth. Now the second constriction at the age of 20 to 25 years. This is the age of marriage, when we entangled in the arch of marriage. So second constriction due to the arch of aorta, A for arch of aorta and A for arch of marriage. 22 to 25 centimeter from the incisor teeth, same as that of 22 to 25 years, the age of marriage. Third one, 27 to 28 centimeter from the incisor teeth, when it is constricted by bronchus. same as that of bachas enter our life at the age of 27 to 28 year. So B for bronchus and B for bachas. Look at her, she is very much annoyed. Now fourth constriction of oesophagus is at oesophageal hiatus, which is 40 centimeter from the incisor teeth. And fourth constriction of freedom of life when we reach at 40. At the age of 40 itself, we declared old. You don't have to go there. You don't have to eat much. Yes, there are so many restrictions in our life. So O for oesophageal hiatus of diaphragm and O for old, which lies at the 40 centimeter from the incisor teeth. Now clinical application of this constriction. Now is there any tricks to memorize? Yes, it is tricks only. So T for tube. At this side, these constrictions, where the surgeon feel difficulty. So we should aware that where we can get difficulty to introduce the gastric or esophageal tube. So, and I for impaction. This is the site for impaction of foreign body, maybe quine. And this is C for carcinoma. This is also this favorable site for carcinoma. As for stricture, caused by the caustic drinks. Okay. And why we have to know that this much length is necessary from the incisor teeth at this constriction? Because we have to introduce fiber optic endoscope into the esophagus for up to that much of length. And these marked the 25 centimeter, 15 centimeter, these are marked. And up to that mark we have to introduce to reach at that site, the required site. Okay, because these are the site for the carcinoma, maybe the carcinoma, foreign body impaction or the strictures. Now coming to parts and relation. Esophagus is divided into three parts, that is the cervical part, thoracic part and abdominal part. In the neck, it is cervical part which is 4 centimeter long. In the thorax, it is as it passes through the superior mediastinum and the posterior mediastinum, and the length is 20 centimeter, 5 times. Abdominal part, only small piece, that is 1 to 2 centimeter. Cervical part, it starts from the cricopharynx up to the upper border of sternum. Thoracic part extends from upper border of the sternum up to the oesophageal hiatus, which is at the level of T10. And abdominal part from T10 to T11, where it intermingle with the cardiac part of the stomach. Now coming to its relation, in the cervical part, this is the cut section of the neck, and here is the esophagus. Just anterior to that is the trachea, and laterally we all know thyroid gland lies anterior to the trachea and it goes laterally up to the esophagus. So in lateral relation there is thyroid gland and anteriorly trachea, and in between the trachea and esophagus there is tracheoesophageal groove, a pair of left and right recurrent laryngeal nerve. Here it is written. And posteriorly there is cervical vertebra. So what are the relation of the cervical part? Posteriorly cervical vertebra, laterally lobes of thyroid gland, and anteriorly trachea and recurrent laryngeal nerve. Now coming to relation of thoracic part. We all know esophagus is the food pipe. It's foodie. Just think that esophagus is a person which is very foodie in nature. Okay, so Tarla Desai, a great cook, she prepared dishes in front of her. So what will be the anterior relation of the thoracic part? Tarla Desai. You can see here, this one, the muscular tube in dark grey color, this one is the esophagus. Just in front of that is the trachea. From above downward it is written Tarla. First trachea, then comes arch of aorta. This is arch of aorta. Then right pulmonary artery. Here is the pulmonary trunk, and the right one is in relation, anterior relation. Okay, right pulmonary artery. Then this one is the left bronchus, which comes in relation with the esophagus. Then comes atrium. This is left atrium enclosed within the pericardium. And then comes diaphragm, which comes in anterior relation, because diaphragm is parachute shaped. So it comes in anterior relation also. So Tarla Desai. T for trachea, A for arch of aorta, R for right pulmonary artery, L for left bronchus, and A for atrium. That is left atrium enclosed within the pericardium, and D for diaphragm. Coming to posterior relation, this is very high that this person, oesophagus, very high-fi. Her friend Virat and Anushka accompany her on dining table in the back. So what is the back relation? That is the posterior relation. Virat, Anushka accompany her on the dining table, D. So decode this. V for vertebral column, what we are seeing in the thoracic part as well as in the cervical part. There is a vertebral column in the posterior relation. Right posterior intercostal artery. There are so many posterior intercostal artery arises from the descending thoracic aorta. As the descending thoracic aorta is on the left side, so right one is crossing, going to the right side. So it crosses the esophagus from its posterior aspect. So there are many posterior intercostal artery, the right one only. And then T for thoracic duct, azygous vein and hemiazygous vein. Okay, all these are in the posterior relation as well as the descending thoracic aorta. Here we can clearly see that descending thoracic aorta is in the posterior relation of the esophagus thoracic part. Now in the right side, she is very foodie, so she is asking for more food. What we are seeing here, this is esophagus, and in the right hand side she is asking for more food, or A for azygous vein. This is in the back as well as on the right side. So it will come in the posterior relation as well as on the right side relation. So azygous vein, and you suppose L is silent, so lung with the pleura, U, or, and R for right vagus nerve. Here we can see this one is the, from here the right vagus nerve is passing. And left hand holding money. With the right hand we ask for food, and we from the left hand we used to hold money. So daulat on the left side. Descending thoracic aorta we have seen. Then daulat, A for arch of aorta, lung with the pleura, U, just think that L is silent, lung with the pleura. Left subclavian artery, left recurrent laryngeal nerve, again arch of aorta because A is again here, and T for thoracic duct. Now come to this figure. On the left side, this is daulat, that descending thoracic aorta. This one is descending thoracic aorta, and also arch of aorta. U for lung and pleura, here the lung and pleura, here also lung and pleura. Lat, left subclavian and the left recurrent laryngeal nerve, and T for thoracic duct. comes in left relation. Now relation of the abdominal part, while it enters inside the abdominal cavity, is very 1 to 2 centimeter. In the anteriorly there is in relation with the left lobe of liver. On the back side of liver, on the left lobe, there is a depression. There is impression of oesophagus, and there is left gastric nerve. And posteriorly there is left crus of diaphragm and right gastric nerve. Now coming to microanatomy, that is histology. We all know the histology, there is MS. From inside outward it is mucosa, then submucosa, muscularis externa, and then serosa. Mucosa again divided into epithelium, lamina propria, and muscularis mucosae. And epithelium is non-keratinized stratified squamous epithelium. Why we learn about the microanatomy while reading gross anatomy? Because here the type of epithelium, that is non-keratinized stratified squamous epithelium, get changed into the simple columnar type, which is of the type of the stomach type of epithelium in case of Barrett oesophagus. So we have to know about the microanatomy also. And second thing is that the muscularis externa is made up of outer longitudinal and inner circular. There is variation in this, that in the upper 1/3 both will be of skeletal type, that we can have voluntary control. If any foreign body is impacted in upper 1/3 of the esophagus, we can spit out. And in middle 1/3 of the esophagus, the muscularis externa, outer longitudinal is skeletal, inner circular is smooth muscle type. And in lower 1/3, which signify that partially we can spit out the foreign body. And in the lower 1/3, both, that is outer circular and inner longitudinal, both are of a smooth muscle type, which is involuntary. We can't spit out. Now coming to the development, what we are seeing here is the cranial part, not cranial most, it is the cranial part of the foregut from which the esophagus is developed, and just ventral to that is the respiratory diverticula, which further divide and give rise to lung buds. And then what we are seeing here, it gets separated. Here there is a communication in between these two canal, and later there is septum developed, esophageal septum, and it becomes separate. There are two separate lumen. Why we are discussing development? Because if this septum will not develop, there will be communication in between these two, which will lead to tracheoesophageal fistula. Now coming to arterial supply of esophagus, cervical part is supplied by inferior thyroid artery. Because cervical, and the cervical part, what we are seeing, there is in the laterally there is a relation of thyroid gland, and so inferior thyroid artery, thoracic, the bronchial artery, and the descending thoracic aorta. And in the abdominal part, it is supplied by left gastric artery and inferior phrenic artery. But how to memorize it? The cervical, सर पे ईटा मार के सर को फोड़ा जा सकता है, that is inferior thyroid artery, ITA. I'm just joking. Inferior thyroid artery, it is the branch of the inferior thyroid artery is the branch of the thyrocervical trunk, which is the branch of the subclavian artery. Okay, and bronchial artery, and this is descending thoracic aorta. थोड़ा सा बा को भी याद करना चाहिए, एंड दाता, डिसेंडिंग थोरासिक एओर्टा, दाता, थोड़ा सा हमेशा बा को भी याद करना चाहिए, और बा मीन्स माँ एंड दाता मीन्स भगवान को याद करना चाहिए। सर पे ईंटा मार के सर को तोड़ा जा सकता है, ठीक है। एब्डोमिनल पार्ट, एब्स, एब्डोमिनल पार्ट का मान लेते हैं एब। एब अच्छा हो सकता है अगर लगा आईपीए। आईपीए एक तरह की बियर होती है जिसे पीने से एब्स अच्छा हो जाता है, तो लगा आईपीए। इस तरह से हम लोग याद रख सकते हैं। लेफ्ट गैस्ट्रिक आर्टरी एंड द inferior phrenic artery which supply the inferior, giving blood to the inferior surface of the diaphragm. Inferior phrenic. Now coming to venous drainage of esophagus, same as that of artery. Here there is inferior thyroid, so inferior thyroid vein. In the thoracic, it is azygous and hemiazygous system. Azygous and hemiazygous system. Okay, abdominal part, again hemiazygous and the left gastric vein. This abdominal part, the venous system is very important because there is portocaval anastomosis. It is supplied by hemiazygous vein. It is the branch of the caval part, that is the inferior vena cava, and left gastric vein, it is from the portal side, branch of the portal vein. So there is portocaval anastomosis, and when there is increased portal hypertension, that will lead to oesophageal varices. What we are seeing here, these venous communication dilate and leading to hematemesis. Okay, so here we can see this is the oesophageal branch from the hemiazygous vein, which is the part of the inferior vena cava and the caval system, and left gastric vein oesophageal branch is coming here and anastomosing, and it is the part of the portal system. Nerve supply, it is the esophagus is supplied by both sympathetic and the parasympathetic. Parasympathetic is by the vagus nerve and the recurrent laryngeal nerve. Okay, and form oesophageal plexus, and these are motor, sensory, as well as the secretomotor. Whereas the sympathetic is sensory and the vasomotor. Okay, and sympathetic is from the T5 to T9 spinal segment. Here it is not written, but from T5 to T9 spinal segment, the sympathetic nerve is coming out. Okay, and it's here the same, this root value T5 to T9 is same as that of somatic nerve, which is going to the lower thoracic or epigastric region. So visceral pain of the esophagus will refer to the lower thoracic region or epigastrium, which is very important to know. Now coming to lymphatic drainage in cervical, what we are seeing is that here is the trachea, so tracheal lymph node. In the thoracic, there is posterior mediastinal lymph node, and in abdominal part there is celiac lymph node. C. Drink tea in evening. Tracheal T, posterior mediastinal, that is PM, and abdominal celiac C. C, PM, T. C. Drink tea in PM, that is evening. Now coming to the clinical significance of esophagus. This is dysphagia. If dysphagia occurs, the first suspicion goes to the lard, that is saliva. Just a mnemonic, लार शक. पहला शक हम लोग का जाता है लार के ऊपर, that is saliva के ऊपर की वही ठीक से नहीं अच्छे से एसिमिलेट नहीं कर रहा होगा फूड को, इसलिए खाने में दिक्कत हो रही है, डिस्फेजिया, लार शक. That is the lymph node enlargement. A for aneurysm of arch of aorta. R for right subclavian artery, abnormal right subclavian artery. S for stricture and C for carcinoma. These are the causes of dysphagia. Then double O for esophageal varices. When there is a portocaval anastomosis in the lower end of the esophagus, due to it dilate, due to the increased portal hypertension, leading to hematemesis, esophageal varices. Eclasia cardia, there is a parasympathetic ganglia in between the circular muscle and the longitudinal muscle. When somehow it get degenerate or not develop, that will lead to loss of peristalsis, leading to eclasia cardia. Okay. Now, Barrett's esophagus we have discussed. When non-keratinized stratified squamous epithelium get changed into the simple columnar type, and it is a precancerous state. Barium swallow, meal mixed with the barium is given to the patient, and when it passes through esophagus, one radiographic picture is taken, and normally there is constriction at 3 places only in esophagus after taking barium swallow. That is by the arch of aorta, then bronchus, and then of left atrium. And this barium swallow is indicated in case of MUSCA, that is mitral stenosis, stricture, carcinoma, and eclasia cardia. In these cases, we prescribe barium swallow investigation. And F for fistula, tracheoesophageal fistula. Here we can see this is trachea and this is esophagus, which is not communicating with each other. There is a blind tube, and here the lower one is communicating with the trachea, which is most common type. Type B is very common. And C, when both communicate with the trachea. So food will enter into the, here, food will enter into the trachea. It's a grave situation. Thank you.